Well, okay, so welcome back, everybody. I thought we'd celebrate welcoming back by changing the background. So I'm now in an alternate seat. Another one of mine. Right, we now move on to the performance section of the report. And James, you're going to lead off on this. Is James here?
Yeah,
oh, yeah.
I'm here.
There.
I'm just clicking a variety of buttons to just get me all on the right screen and microphone on. So the cover sheet is comprehensive this time. So we've done that on purpose because there's a lot going on. So we've tried to pull out stuff into the executive summary, which is a lot longer than previous, but there's quite a lot going on. So we just want to pull those things out. As we said, COVID's going down in the organisation now in terms of beds, but so that had given us quite a bit of capacity. However, urgent care now is heating up again. So our attendances through ITU are picking up, and that's having an impact. When you look at, just quickly going through the performance pieces, there's just one or two things to point out. So in ED, our performance in April was up by 8 to 10%, depending on which of the two metrics you look at on the previous month. If you look at the graphs at the back of the performance paper, they show where we are in relation to the rest of the hospitals in the country and in the region. And the last 5 or 6 weeks have been incredibly strong performance. We've been in the top, well, always above the top 13 trusts in the country in terms of performance week on week, which is incredibly strong. And that's really good that we're retaining that performance as we get busier. The first couple of weeks in April were low, and that's why April's performance overall is 88. May's performance is 90, just under 97. We're at 96.5, 96.6 at the moment. So that really does put us in the top 10 in the country right now. So what that's proved is, all the work that we've been discussing in board and in performance committees for the last year really shows that we can deliver the level of performance that we were retaining to. So we have been able to achieve that, and that gives that particular work stream that we had, the Making Every Day Count work stream, and the work that we've been doing with Prism for the last year, we can see that our systems can deliver that level of performance, which is fantastic for our patients, and it's been a real lift for our staff to show that we can deliver that. The challenge now is we eke back in the volumes back into ED and the bed pressures out the other side. They're the two big challenges we've got, but it's given us the opportunity to take stock of the systems that we have, to really see that we can achieve it, test all the processes in ED and all the things that we integrate in there. So that's been really strong to be able to get to that, and to the fact that we're still delivering top 10 performance in the country, which is really, really strong given everything else that we're doing in the organisation at this time. So it's a great work from my team there, especially. In terms of cancer standards, we have delivered those. We delivered all the cancer standards apart from 2 patients on the 31-day standard. But if you look at the referral volumes, and that's something that we need to take into account as we do this whole piece, is we received 500 cancer referrals where we normally receive 1,200 in a month. So well under half, running at sort of 45% of the referrals coming in. So again, we can deliver that for those patients, but the worrying thing is what's happening to the work out in the community, and when that all turns back on, the level of work that we're going to be faced with at some point in the future is something that we're bearing in mind at the moment. And in terms of 18-week performance, the elective performance, you can see that the size of that waiting list, so our 18-week position is falling, and to be honest, it's falling dramatically. It's falling like a stone, and that's the same with all other providers. And I talk to colleagues about this across the region all the time. So we're 80.9% RTT performance today. I think we're 70.9. I mean, it's continuing to drop. The number of patients on the waiting list has fallen because we're receiving less referrals in. We still are treating some patients. All the phone clinics are happening, and we are doing urgent and emergency work. So the way we described it in the performance committee is that the tap is turned off, but the plug is sort of half open or quarter open, and so that's why the waiting list has fallen. But the waits on the waiting list are going out significantly, which is why our performance is coming down. I just wanted to say around what we're doing on recovery, because you can sort of stitch together all the discussion that's been happening today through Suzanne's report and Andy's report and through the quality reports around this focus now on infection control and our new North Star objective in relation to our operating model. So we're really focusing on Ashford as our site for restoration in the immediate term. We have a piece of work over there where we've socially distanced the site. The specialties and services over there have put a lot of time in to make sure that they can socially distance in a number of ways, whether that's through geography, timing of appointments, the way they set out their departments, what they do to patients and how we protect patients and staff in those environments. So we have started elective activity in Ashford now. So we have the two day case theatres working 5 days a week now, and we have 3 of the main theatres working 5 days a week. We're looking to increase that to the other 2 main theatres going in Ashford at some point during July, which is linked with our ITU piece and our ITU staffing. But you know, that's the plan. So there is work going there, but as I've said already today, it's less patients per day than we would otherwise do because of the social distancing and all sorts of other measures we're taking into account. We're looking to the independent sector, so we are beginning to, we're setting up to start work for gynae and orthopaedics going through the Woking Nuffield. That's still under the national contract at the moment that the government put in place at the start of the pandemic outbreak. So we're changing what we've used Woking Nuffield for. We lined that up, as David mentioned earlier today, we lined that up for palliative care. Our needs have changed now, and we're winding that into some elective work, say orthopaedics and gynae. So we're making use of the theatres that are available to us on that site, so changing the beds so that we can use that theatre activity. I'm also looking at Cobham to support our endoscopy recovery. And as you know, we've always had problems with endoscopy waits, always, but for a long time in the board that I've been reporting that here, pre-COVID, post-COVID, it's just gone to a level that, you know, is beyond anything that we've seen before. We're in the same place as the rest of Surrey in the rest of the country, really. But we're looking to Chobham as well as getting our own facilities online at some point. That's challenged because we talked about the new operating model and the challenge that we have with some of the St Peter's services being locked into areas surrounded by non-elective patients, and how do we keep those flows separate. But in the immediate term, we're looking to bring online some stuff at Cobham, and we're working on ways that we can bring online some of our services, our diagnostic services on the St Peter's site. But that's taking a bit longer to work through some of those pieces. Imaging, we're focusing that at Ashford as well. So we were only doing urgent and emergency work. We're now bringing on some of the sort of time critical imaging. And there was a lot of stuff returned to the community and to other providers, other consultants in the organisation. So that work's been reprioritised by our own clinicians and primary care, and we're working through that as well now in terms of MRI, CT, plain film at Ashford and ultrasound at Ashford. Also, we're looking at bone density coming online at Ashford as well. So we're beginning to get that coming back on, but in total, it's going to be around 55–60% of our activity comes online because we've still got the current issues and restrictions around the St Peter's site. In terms of outpatient activity, how we manage post-COVID, many of you have seen the message that we put out last week, so I used Suzanne's message of the week to do a reminder around virtual clinics, because we've moved significant volumes of work to the telephone, but actually that's not really sustainable. What we need is this environment. We need to be able to see patients just like this, and that's pretty much 99% of what you get from a face-to-face consultation. So the work the team and I are doing is really working out how do we get people to move to the new technology, move our clinicians from telephone to these virtual platforms, and that's a challenge that we've got. So you can see that most of our work is by the telephone, and it's getting people to go to the next level, and then they'll, just to see how great it is, and then we'll be able to roll that out. So we need to have an ambition of at least 50% of our consultations by that platform, and that's what we're working to achieve. I mean, we were working to achieve this. We had an outpatient transformation program prior to COVID, but post-COVID, while we're in lockdown, I mean, there's no greater motivator or impetus to really push out the video platform, which is what we're trying to do at the moment. So that's one that we really need to work on. Shall I leave it there, Andy? And if people want to, there's quite a lot. There's quite a lot in there.
There's a lot there. Marcine's got a question.
Oh, unmuting.
You are unmuted.
I am?
Yeah.
Oh, you can hear me?
Yep.
Okay, there's a cross in my line, but that's all right. James.
Hi.
I've seen a lot of this at 2 committees, so my question is your new information. The increased attendances at A&E, what are we seeing? Back to the old ways of people inappropriately coming, or people now needing to come and are appropriately attending? And what is their main cause? Thank you.
Yeah, so I mean, it is. I mean, our number of the medical take especially has gone up as well. So patients are being admitted to the organisation. So if you use that as a proxy, I realise that we all realise there are risks of using hospital admission as a proxy for correct attendance. But our hospital admissions is going up as well. So patients are not just coming for small issues. It is a marker for me that our number of admissions are going up, which means hospital consultants believe that they need acute care. That's causing a level of pressure on beds, but it is our marker that I think it's appropriate. There's lots of work going. We're part of there's lots of things going on across the health community. We're part of a pilot for Think 111, which is a pilot program with 111 around booking in via an app, so that we can, the drive is to move away from attending, just walking up to A&E, is to be filtered by 111 to the correct disposition, which might be a walk-in centre, might be a primary care provider, might be a pharmacy. So we're part of that as well. I mean, there is a recognition across the health community that the danger is that people start rocking up for their hurty toe, and that's going to put pressure on that we don't want. If we can retain some of the learning through this and some of the behaviours in the public, that's great. And so we're part of that sort of program too. I hope that helps.
We've got Merrick, then Mike.
Yeah, it's just a question. I mean, obviously, a lot of the procedures that we're doing are much slower because of all the precautions that have to be taken. But are there any procedures where fundamentally we can't find a safe way of operating?
Well, we certainly have some challenges, Merrick. I think that's a really helpful point, because we do have some challenges at the moment. Endoscopy is a key concern for us. So nationally, it's not clear how to turn on that service. It is significantly aerosol generating, having a camera and air blown inside you. So that is a challenge nationally around how do some of those things are getting turned on again. So we're not alone in that one. We're working through how we can get our facilities online, and in parallel, we're working through what's the national guidance around how we do endoscopy, for example. At the moment, we're using the Runnymede Hospital next door. We've been in there using both of their wards from the outset, one for surgery and one for paediatrics. We're using 2 of their theatres since the outset as well, one for urgent cancer and one for orthopaedic trauma. So we're able to get our urgent stuff through there. But the time critical stuff, Merrick, is a challenge for us. We've got, at max, we will have probably the theatre in the Runnymede and the trauma theatre, and the 7 theatres at Ashford. And so that is a challenge, because we're normally running 13 elective theatres. So we've got to work through how we can do that, make sure that we're prioritising our time critical and our urgent patients, working with the independent sector to get more capacity, and working on what our new North Star objective means to us in the hospital and how we can run services in that way.
Okay, so but there's nothing that fundamentally we can't do. I know we don't do dentistry, but if we did, that would be one of the things that we might talk about in this context. It's just we're operating in lower capacity rather than.
It depends what you mean by dentistry. We do oral max fax, we do orthodontics, we do the top end dentistry that dentists can't manage. So we do have, our department takes 95% of that work comes from dentists referred in by primary care dental practitioners. We are managing some of that work, following the right PPE precautions. We are doing some of those cases, and we have been seeing some of those patients throughout.
Okay, thank you.
Okay. Just before I call on Mike, Suzanne, do you need to make a comment? I see you've got your hand up, or was it a question?
It was
sort of a response, really. So I can do it now. I wanted to respond to Marcine's comments about inappropriate attendance, and then maybe give some national perspective around the data I'm seeing.
Okay.
Just looking at. So, I mean, I wouldn't usually describe attendance at the department as inappropriate. Because my feeling is that whilst the patients might be coming here for things that could be managed elsewhere, we haven't actually, the reason they're coming here is because we haven't actually worked out as a system how to ensure that they have access for the thing that they do need, or that they appreciate where that is, or how to get to it. So what we have seen is a big adjustment in the volumes of type, and I always get these wrong way around, James, the low acuity patients, UTC 1, type 3. So so that would be the patients you might say, well, actually they can reasonably access care by other means, and that's mirrored across the country. And what's being seen across the country is yes, there's a return to what you might consider more normal patterns, but it doesn't seem to be in the type 3 categories. So as James rightly says, our position is being reflected nationally. So it does appear that patients who may have come here for sort of lower acuity aspects are now continuing to use the other means that have been enabled, technology, 111, online, whatever, and that the patients that are being brought to us are patients that do need hospital care, and that's similarly reflected in the data. Also talking to the ambulance services, they're describing something very similar, and that although their call rates have gone up fairly slowly, they are still maintaining better than sort of historical conveyance performance. So see and treat and hear and treat is continues to go well. But the overall picture nationally is that what colleagues are describing is, yes, things have returned from an urgent emergency care perspective to higher volumes. It's still roughly at around 2/3 of what you might expect to see at this time of year or on any previous year. And actually, we had quite a steep rise, and it's sort of flattening off a bit. So we just have to keep an eye and see if that continues. I think the piece that worries me, and James might want to elaborate on this, is mental health patients. So some of the enhanced urgent emergency care facilities for mental health crisis that were opened in response to COVID crisis have been shut rather suddenly. And although we may not have had a huge amount of support from that facility, you know, it'll be something I'll be raising at system board, because, you know, that should have been done as part of a system response, not unilaterally. But of course, now what we're seeing is some of the consequence of that, both of social distancing that has been implemented across the mental health trust, and a rising number of patients attending EED with their challenge. And clearly the patients that need a bed, so have been, you know, deemed as unwell enough as to need inpatient mental health care. We're struggling sometimes to get a bed, and we've been seeing some breaches around that care, haven't we, James? So I think it's just worth describing that.
Apologies for my term inappropriate. What I meant to say with the correct language was in the wrong setting, i.e. not needing acute care.
Yeah.
So apologies, Suzanne.
That's all right, Marcine.
Me back in my box.
No, only very gently.
So we've got Mike next, I think.
Yeah, hi, James. Thank you. So just with respect to the sort of ongoing technology, non-face-to-face interaction, I wonder whether we were using any of the learning we have from risk and offering people guidance. And I guess what I mean is, David makes the point really clearly that the hospital would become an increased risk place for infection. So should we be stopping people over 70, people with diabetes, people with cardiovascular disease? You know, there's a whole group of patients that we could give guidance for. They should be seen in a different, lower risk setting. And I wonder whether we might, you know, describe that for people to as a guide.
Shall I come in, James?
Yeah, David, do you want
Yeah,
to?
I think it's an absolutely brilliant point, Mike. And I think one of the things that's come out of this COVID crisis is the PCNs do appear to have kind of emerged as a real entity, and I suppose that's probably the vehicle where we need to kind of support and encourage where those groups of patients could be reviewed distant from us. So I think it's an absolutely brilliant point. I was going to come in as well on the mental health side of things, and actually. Suzanne made the point that they've got a lack of capacity because of the social distancing, which is happening in all the healthcare settings, and that is causing us a big issue. Lots of other trusts were simply admitting these patients into general wards, which doesn't really solve their problem. So actually, we did have a meeting with the Mental Health Trust, and if you remember, before all this started and before when we were building the A&E, we were actually talking about an integrated acute mental health assessment unit, and I think that's and where we came to it was a slightly fractious meeting, because obviously we're putting pressure on them operationally. We feel that they're putting pressure on us, and actually the patients are losing out in the middle. What we came to is we are going to meet, because if it's space they need, we need to find them some space where they can have some beds and run a mental health assessment unit attached to our A&E. That seems to be the solution, really, rather than us looking after these patients with probably the wrong staff in the wrong setting.
Interesting. Okay, thank you, David, for that. I've got Chris and then Merrick.
Yeah, thanks very much. Couple of points just to build on what Suzanne and others have been saying around what we can do in moving on in terms of the new model. And I just wonder, James, in terms of where it's really obvious is this whole area of walk-in attendance. That's the area we've got to address somehow. And I just wonder whether in an environment now which is probably more receptive to messaging, even though some people don't actually take it, whether there's an opportunity for us to go either direct by video consultations or supporting, if you like, GPs, if you like, education as to when you should come in, you should walk in. So not just allow people to walk in as we've embraced it and say walk-in centre. It's almost providing people with very clear guidelines as to when you walk in, or Mike's point, if you're vulnerable, you stay away. So I just wonder there's a communication piece that might help us in maybe addressing these issues that we have around walk-in attendance.
Yeah, I mean, there is, as I say, we were in this pilot, which is the NHS 111. So it's Think 111 or 111 Think. It's designed so that people go onto the app and get directed to the most appropriate place and get booked into appointment at ED rather than just rocking up. So that the days of walk-in appointment, just walking into ED, are gone, and then you come into an appointment slot. And that's a part of the pilot we're with. On the Think 111 piece, so that's new, and we're just gonna that will start relatively soon, and we already have some bookable slots. But this is about, can we get the populace to book in and get to the right place, and if they are coming to us, get booked into that slot. We're also looking at another product as well, very similar to that, which is what we're looking at ourselves, called Babylon. So we're very much on that, Chris, looking at what IT solutions there are to get people booked into our historically walk-in type services.
Great, thank you for that.
Yeah.
And my other point was, I've got friends who are dentists who are very concerned because it's prohibitive at the moment. They're obviously not allowed to undertake any consultations, and the guidelines are, particularly around drills that disperse COVID into the atmosphere, that they've got to be, in the new world, 1 hour waiting between appointments, which is a real concern for them. So I just wonder whether we might need to prepare for some sort of change in our model where dentists may actually go out of business, or we may have a greater influx of people wanting to come in for the dentistry type issues.
Yeah, no, that's really helpful, isn't it? I mean, the last thing we want to be is become a dentist surgery, but I think, I mean, they're the sort of things that I mean, we have historically been looking at what we think that actually we've got more things coming into our organisation from primary dental care practitioners than we should. So, the thing that we've been looking at in the background is how do we sort of push more back compared to other providers we seem to take more in. Well, it's a really helpful point, Chris. It's really helpful to flag that up to us. You know, on one level, primary care dental practitioners are facing the same challenges we are in every single service that I've been highlighting today, whether it's theatres, clinics. We have to have that huge turnaround between cases now, for cleaning, and there might be donning and doffing in some instances, but it's still that air settle between cases. We do big appointments so that patients are out the building before the next one arrives. We're very much in that place as well, and it's across the whole range of practitioners outside, optometrists, all sorts of things are in similar positions. So, you know, the world is changing. We have to reflect that, but it's helpful to it's very helpful to raise that. No, that's
I think just to say that on the Chairs Forum this week, they were saying that there's a lot of pressure, political pressure building on around dentistry. A lot of MPs are very unhappy because they're being contacted by their constituents, rightly so. And I think, you know, it is front of mind in the NHS, the dentistry, because, you know, anybody who's ever had a tooth infection will know that it is so debilitating. It's horrendous that it can't get proper treatment for that. So so we've got Merrick, then Andrew.
Sorry, I didn't have my hand up, or apologies if it was.
Oh, you have got your hand up.
Sorry.
Okay, no problem. Andrew.
Just 2 points. In terms of digital communication with the public, having spent a day yesterday just trying to get a basic communication with GPs through their online services and some of the frustrations of trying to make any of that work, I'm conscious that sometimes the public sector, because it feels it needs to have all the information online, can sometimes create quite confusing situations for the public. And sometimes it's very difficult then to get hold of a real person to speak to, which causes a lot of anxiety to people. It's just a general point about making sure the communication pieces in this new world are easy for people, and that the human contact is easy to have, rather than getting caught with robots and all the other things that is going on at the moment. Because I know some are very good at this, and there's some very good examples in terms of this online communication with the public. And there's some that I think are rather terrible at it. And it's just a point in terms of testing these things with people who are not inside the system, so that the things really do work for the customer. That's one thing. And then the second thing was with regard to James, the environment and the whole access to environment for people and how that new world's going to work. I've been talking yesterday to Chris Riddle about all this and what some of their international experiences around these kinds of issues, because in many ways we have been, I think, and you can see it, quite lax. And I'm very conscious to be a friend of mine, a school teacher, who's actually had to stop work in his early 50s because he caught a bug in a hospital that's put his life really in danger, actually. So that I'm going to come to Suzanne with some thoughts and Tom about that whole thing about the entry into a hospital and that interface in this new operating model. Just some thoughts really about how one really creates that distance between the passenger side, what we call the passenger side, and the air side, if you know what I mean, like you get in an airport. So I let you have those thoughts, because it really, both these things really need to work for people. It's really important.
Yeah, thank you. I'm keen to be involved in that. I mean, we can also show you the work that we've done at Ashford. It's making the current architecture fit, which is not the same as you're describing it, but is how do we make the current, we've done a lot on Ashford, a lot of thinking there, so that'd be really great to show you what we've done and progress that together.
It might be good to bring in Chris and Neil to that conversation, so we have a detailed conversation about some of these points. So maybe when I send the thoughts, we can try and make sure it's copied into you so that we create a joined up conversation. Does that help?
I was just thinking, James, that piece of work at Ashford, which we saw yesterday, which is such a good piece of work, should really go into the reading room for the board as well, because it is, in my view, it's such an excellent piece of work that's been done, and that's the exemplar. So if you could just liaise with Sal and get that into the reading room, that'd be great.
Yeah, certainly. And I think the video message that we did yesterday would be good to share that with board as well for information, because I had a lot in there about what we've done at Ashford.
Yes, it doesn't frighten the children, but
Can you email me some of that, James, just so I can have a look at it? Is that right?
Yes, of course. Yeah, absolutely.
Thank you.
Okay. Right. So any final questions before we move on from this? James, thank you, and thank you for that comprehensive kind of summary up front as well. There's so much going on in your area. I think it did make things a lot easier, and I know it's made things easier for the committees as well. So thank you for that.
Thanks.
Merrick, anything you want to draw our attention to on modern healthcare minutes?
I think the main thing to say is that we've covered off actually in the private board quite a bit in modern health. I think the thing is to assure the board that within the context of COVID and the fact that the operations we've covered have changed and funding mechanisms have changed, we see work done to retain quality of resources and money in particular, and understanding the movements of money in what are very unusual times. We've also seen a number of quite significant investment papers which across a variety of areas which have all received extensive scrutiny, and we don't believe that any of that scrutiny was in any way limited by the COVID time and restrictions on the executive.
Okay, thank you. Unless anybody's got any questions on the minutes themselves, we'll move on. Okay, Chris, on the digital side, back in January now, quite a while ago.
Yes, the focus for that really was very much on the EPR, and we've moved on since then with several meetings of the EPR Joint Committee with Royal Surrey. So I thought I would just bring you up to speed with where we are, and Simon might want to chip in as well, as of minutes of the 2nd of April. So it's just Ashford and St Peters working together now, as you probably know. The project is going to commence on the 10th of June, all fingers crossed. We go live hopefully around October or so in 2021, and we're hoping we do it together, but that's something to be decided rather than just Royal Surrey going first. We've had some resourcing issues, which we brought in a company called we're bringing in a company rather called Nautilus Consulting, and the business case approval, the budgeting approval for that has been through our modern healthcare committee, as it has with the Royal Surrey, and I think that's progressing now. So that's really good news, because without that resource, it wouldn't be able to progress. Simon, you probably all know, is the senior responsible officer. So he's driving all of this, and I'm going to be chairing the joint committee in future, but we're sharing and rotating the chair with Ned's from Royal Surrey. So in terms of point of collaboration, I think that's all very positive, and that's all I really wanted to say at this point, unless anyone's got any questions.
Okay, thank you, Chris. Any questions for Chris? Great to see EPR still pushing on. I mean, it's so vital for us, going forward. Okay, Marcine, People Committee.
Thank you, Andy. We've had some minutes of March, April, and I'll just give a quick update on May because I don't see a People report, and then maybe Louise wants to say anything. So March was all about planning for COVID, changing our processes to accommodate fast tracking, onboarding staff, changing a new style of induction, and getting guidance from managers. April was really responding in the thick of it to move to a instant staff sickness reporting, getting real-time information, starting to really get into well-being and health for staff, and staff testing, and kind of sorting out responding quite quickly. Louise and her team developed a really comprehensive workforce strategy that we've seen twice and is excellent. And May, what we've started to now see is some of that embed and how they're moving forward. So sickness levels went up, but not as high as national prediction of 30%. Ours went up to 15.5. Ours are still higher than some of our colleagues, and I'm sure Louise might want to talk about that. So we have seen the staff sickness levels now come down. We have done more staff testing, but again, we've seen a lower percentage of staff actually having a positive response. And our moving forward is really to do this risk assessment about the individual and their role, in terms of everybody, not just BAME staff. And also probably looking after the psychological well-being of our staff. And we're working with the University of Surrey with a baseline kind of psychological well-being questionnaire. And that's still being developed, but will be rolled out soon. So an amazing amount of work. They completely transformed all of their processes in a very rapid time, and really on top of it. So that's how I think I would respond to 3 people committees, March, April, and May.
Okay, Louise, anything you'd like to add?
Yeah, I mean, Martin's covered a huge amount in that last few minutes. I'm happy to share our strategy slides if that's helpful with members of the board who may not have seen them. I think at the moment our challenge is to be able to dynamically react to all of the changing policies, as it has been for the last few months, but Suzanne's already referred to it. We're now trying to get our heads around the track and trace guidance and what that means in terms of potentially the number of staff that will be asked to self-isolate in addition to those that are already shielding or self-isolating, and obviously then working out whether that has a significant impact on our resources. But also the antibody test, so needing to roll that out, working out who our priorities should be and how we do that in a way that both attempts to give people some form of assurance, but also knowing that it isn't a test that means that you can automatically consider yourself to be immune and not at risk of further infection. So trying to get the balance of that right. I think the issue that we've spent a significant amount of the last sort of 10 days working through is the potential for parts of our workforce population to be more affected by COVID. And this is a new virus, so we are learning about this all the time, but the evidence showing that with other risk factors, our BAME staff may be more at risk than their other colleagues. So we've spent a lot of time rewriting the risk assessment. It's a really tricky thing to get right. So we've been using external guidance. NHS Improvement have been working on a scoring matrix, which we've looked at and decided to adopt. But obviously, once people have gone through that scoring process, we need to be able to give people the ability to mitigate their risk. So, you know, if you are working in an area where COVID is present and you are somebody that may have an additional risk factor, then are you receiving the right level of PPE? Are you receiving the right level of training? Are there other areas that you could be redeployed to? So complicated, and as Susanna said, you know, an issue that is causing some significant anxiety in the organisation. So making sure that we get that right. So those are the sort of just other additional things to talk to, but happy to take any questions and share the strategy documents more broadly if that's useful.
Yeah, I think the strategy documents, a bit like James's document for Ashford, should go in the reading room. That'd be helpful. Thank you. Any questions for, yes, Tom?
Yeah, sorry. So we just on the track and trace or test and trace or whatever. We've already heard about the nosocomial transmission and infection between patients, but will test and trace enable us to monitor that for members of the team, the transmission of infection that actually happens for members of our team in the workplace? And is that something we should be then using as a measure of the success of our operating model?
Got a great question. I'm not sure if I know the answer to that. David might be able to answer that one more thoroughly.
I mean, it's a really good question, and we spoke about it earlier, didn't we? About when we have a staff member who develops symptoms when we have a staff member who develops symptoms, and whether we can see, well, what areas have they been? Because when we looked at our staff and we saw sickness, we wanted to see if there was patterns of it, which would then suggest that there were areas which needed more education, more protection, or something else. And it is quite hard when we've got our staff moving around. And one of the problems with this track and trace is that all the staff will have loads of contacts because they're busy walking up and down, even if they're social distancing. So I don't know, but I mean, it would be good just trying though, wouldn't it? I think we just try and see what the data is.
Yeah, and what I've asked the team this morning to do is to establish a new way of being able to identify people who are contacted by the track and trace centre, so that we've got that ability to report people who are self-isolating in a different way.
Okay, thank you. Any other questions for Louise? And I'm just aware that the amount of work that your team's had to do, Louise, and you personally. So thank you for all the work you're doing, you and your team, because it's been I think a real steep curve for you, hasn't it? The last couple of months. So thank you. Okay. Right, we now move on to the regulatory piece. The first piece is an information piece coming up from the committees, which is the Board Assurance Framework COVID-19 update. And Suzanne, you've got your name against this.
Yeah, thank you, Andy. And Sal might be able to help me out. I mean, I think the paper's pretty self-explanatory. The thing that I'm actually meeting with Abby and Sal after board just to make sure that we've gone through everything. But the thing I'm particularly pleased to see is this adjustment in recognising the pandemic as an issue which can influence our risks, and that's well described in the paper. And the inclusion, which I think is wise. Thank you to the Integrated Digital Committee for a cyber security and data protection risk there as documented. So I won't say any more unless Sal wants to add anything or anybody has any questions.
Sal, anything to add?
No, nothing to add. Thank you, Andy.
Okay. And I think we've all seen these in the various committees anyway. This is just an update that the committees have signed off. So unless there are any queries or questions, we'll move on. Thank you.
Thank you.
Now this takes us to the NHSI self-certification, which, as I understand it, we don't send off anymore, but they could come and audit it if that's right. And Simon, are you looking at this?
Yeah, that's right, Andy. Essentially, it's one of 3 of these kind of self-certificates that we do each year. This one focuses on governance. I'm glad to say there's nothing particularly highlighted in there. If you go down the appendix, all the answers are kind of positive and favourable. I think there's just one area that highlights the annual planning process was curtailed this year. So I'd imagine all trusts are putting that one in. But there's nothing particular to highlight to you. I think everyone will recall doing this last year. And more or less it's the same arrangements as then. So unless there's anything else to raise, it's for adoption, really, approval.
Okay, so any questions on anything in there? I was exhausted by the time I got to the end of it, I have to say, going through it, but it's not a simple thing. So we need to approve this, Simon, do we?
Yes, please.
Okay, so can I take it then that we approve this?
Yeah.
Anybody who does not approve it, speak now. Okay, thank you very much. That's approved. And then we move on to standing orders. Now this are, again, we remember from previous years, comes up. Sal, are there any changes that we want to highlight?
No, there are no substantive changes to the standing orders this year, Andy. So, yeah, we just ask for approval from the board.
Okay, so I'll take that people have read. I picked up one typo, Sal, before Marcin says it. So in 261, para 261, we've got the board and then the board again. So we've got the board could appoint deputy chairman. We've just left in an odd the board.
Okay, thank you.
That was the only one I picked up. Anybody pick up anything else?
I did.
Yeah, it's a surprise, Marcin.
It's interesting, really. I have 2, all on page 13. 3.2.3. says 1/3 or more directors can call a meeting, even if the chair doesn't want to. In directors, the definition is that non-executive or unified board, all directors. And 3.3.4, a director requiring a matter to be included on the agenda must be sent to the chairman 10 days before the meeting. But it doesn't actually say whether the chairman can disregard that. So just 2 points of clarification.
Oh, okay.
And this is the first time I've actually read this in detail, so you wouldn't be surprised.
Thank you for doing it. Yeah, I did highlight another one as well on 342 that the board of directors must send a copy of the agenda of the meeting to the Council of Governors, and I was going to ask, do we do that?
So we obviously make the agenda available publicly.
But that's not what it says
Ahead
in the...
of. Yeah, we'd need to check if we
so it looks
physically send it.
I mean, 342 seems send a copy of the agenda. So we just need to make sure we're doing that. And
Yeah.
if we could pick up Marcine's points offline
Yes,
as well.
Of course.
And we'll have
Thank
a look
you.
at those. So subject to those things we are going to look at again. Can we approve those, please? Yep. Okay, thank you. And next we have the board register of interests, and we've got some additional ones on there that people have. Thank you for everybody for adding those in. Has anybody got anything that they have forgotten to add in that they would now like to add in? Is everybody comfortable that all their interests are displayed there?
Just one amendment on me, Andy, that I'm no longer the Medical Advisory Committee chair for the Runnymede. We did find someone there to do that role.
Okay, so that's just a delete, is it, David?
A delete, yeah.
Okay, thank you. And we've got Mike's non-executive position with Frimley down there. So okay, so that's just to receive it. Obviously, this is available on our website. Sal, that's right, isn't it?
Yes, it is.
So it's publicly available. It's just to make sure that it is up to date, and the board receives it twice a year, I think. Okay, thank you. In which case we will move on to any other business. Has anybody got? And I've got one. But any got? No. It's from our discussion earlier. I know we could record in the minutes our gratitude to the team, but I just thought we probably ought to send, and publish a letter and put it down all the different comms, Rialto and everything else, just how grateful the board is of all the efforts that have been made by every member of the team. And I would sign that on behalf of the board. I just wanted to see if people thought that A, it was appropriate, and B, it would be supportive of that. Yeah, because I just think just recording it in the minutes, who's going to read the minutes from the team? Not very many, but at least we could do something down the normal channels, the comms channels. Suzanne, you okay with that?
Yeah, no, absolutely. Good suggestion. I think the only thing we do is just crafting the words to make sure that I think the point that David made and Louise about those shielding have done their bit by doing that and so on.
Absolutely,
and so on.
Absolutely.
Thanks. Yeah, very happy to support that idea.
Okay, so Sal, could you get the comms team to
yes,
into
no
action
problem.
on that?
Yeah,
thank you.
No problem.
Now, I think we've had one question from the public. Sal, or have we got more?
One that I'm aware of. Sorry, I'm just trying to.
Liz, have you had anything?
It's just the one, Andy, from Rosemary Moore.
From Rosemary.
Yeah.
So our good friend Rosemary is asking whether we would be seeking to stream these minutes in the future. And I think I am not convinced you can stream a Microsoft Teams meeting. So I have got nothing against live streaming of meetings. And of course, when you are all in one place, several boards do that. When you are doing it virtually over Microsoft Teams, I don't know if the technology allows us to do it, but happy to investigate that. And if anybody else has got any thoughts.
No, I mean, I'm supportive of the principle if we can find a technological
Yes.
way to make it work.
Yes, it's one of those that works well if you're all in one room.
Yeah.
But when you're on this, I'm not so sure. But we will take that away because Rosemary will undoubtedly listen to this. So
Yeah.
Rosemary, we will take that away and look at it. But the problem is with meeting on Microsoft Teams, it may not be possible to stream it. But of course, we are making them available online for you to look at. So any thoughts on today's meeting, how that's worked?
Informative and constructive, Andy.
Yeah.
Whether it's now or later, it'd be helpful to get Neil's reflections as a sort of an external or objective observer. Maybe
Yes.
some feedback, and then if there's anything substantive that's really helpful, I'm sure there's lots of help. We could bring that forward at a later point.
So Neil, any thoughts? You've sat in through both meetings now.
Yeah, well, thank you for letting me observe today. I think it's really important for the board to sort of keep that level of analysis, accountability, challenge, and then reflection in terms of what's going on, and then to do that through a sort of COVID and non-COVID lens in terms of going forward, and to maintain a degree of agility in terms of how we respond to that, and both obviously today as a Microsoft Teams, and then how we might do that, and the point you just raised there in terms of how we might sort of stream that. You know, things have changed, and we need to reflect, you know, the boards, how we respond to that in a sort of, and using the sort of the positives that have come out of this piece, you know, into a board level performance. I think would really be useful.
Okay, thank you, Neil. It's always helpful to have somebody who hasn't seen one before, just to reflect. And if you've got anything else you want to drop me a line on, then please do. Okay, so if I'm going to bring this to a close. Tom, if you and Andrew could stay on for a couple of minutes, just Andrew wanted a quick chat. And Sal, Liz, if you could stop the recording, that'd be great. But thank you all for your attention, your detail, and have a good day.
Thanks very much.
I'll give you 25 minutes back.
Thank you.